Hello guys, welcome to the third video in this series. So we'll begin with the first one, that is calcinosis cutis. So from the name itself, I'm getting that this is some kind of a calcification within the cutis, or I can say that something related to the skin, isn't it? So some kind of calcification of the skin is what is meant by calcinosis cutis. So whenever we get a section like this of the skin, the first idea is to understand this is a skin section. So I can see here epidermis here, and I have a dermoepidermal junction which is also called by the name of basement membrane zone, and this is my dermis, and as it comes down it becomes the subcutaneous tissue. Below dermis is subcutis. So in the dermis and the subcutis, I am seeing these kind of basophilic deposits in this base, and these are basophilic deposits that I can very clearly make out. So yes, understanding that this is a slide of calcinosis cutis is extremely easy because it's very characteristic, because they are directly showing these kind of basophilic deposits within the dermis and the subcutis. So that is the most important feature here. This is stratified squamous keratinized epithelium or non-keratinized epithelium. It is stratified squamous keratinized epithelium, isn't it? Obviously. And you can have a foreign body giant cell reaction, okay, where there is lymphocyte, histiocyte and giant cells which are involved. It's a giant cell inflammatory reaction can also occur along with this kind of a deposition of calcium within the skin. So identification of the histopathology specimen is extremely easy whenever this kind of a specimen is given to you in the examination. So what is most important is that calcification can take place in two methods. It can be either a dystrophic calcification or it can be a metastatic calcification. This is a typical example for dystrophic calcification. Okay. So this is one of the most important points so far as the calcinosis cutis is concerned. You are supposed to know this very much thoroughly, that this is an example of dystrophic calcification, which is a type of calcification. There are two types, dystrophic and metastatic. Now this is a disease which is seen most commonly in females, especially in the waist area. That is the most common site affected in females. So I was just going through the surgery textbook to understand what is this actually. So yeah, whenever there is an excessive friction in the waist area of females, typically females, and there is an increased alkalinity of the subcutaneous tissue. So you require excessive friction and also alkalinity. Okay, so these are certain factors that I found over there. One is friction, excessive rubbing of the skin surface, and alkalinity. Okay, whenever the subcutaneous tissue is showing an excessive amount of alkalinity, there is an increased predisposition of calcium to precipitate in the subcutaneous tissue. So this is the method by which the calcium can form these kind of precipitates over there. So these are deposition of calcium within the skin, I mean subcutaneous tissue and dermis. So yeah, no discussion of calcinosis cutis is complete without the discussion of the type of calcification. Let's go to that now. So let us now begin this discussion with the stains for calcium. So these are the special stains for calcium. Please make a note of this. So alizarin red and von Kosa stain, and this von Kosa will stain calcium as a black colored structure. And if you are using this H&E staining, calcium is a basophilic structure. We are aware of that, isn't it? Alizarin red and von Kosa stain. This can be asked in the exam. Now calcification can be of two types: dystrophic calcification and metastatic calcification. So let us try to differentiate them, and these are all probable questions in the exam. So if I start talking about the dystrophic calcification, remember that the serum calcium level of this particular patient is normal. Okay, so there is no excessive amount of calcium inside the blood of this person, while here the serum calcium of a patient who is suffering from a metastatic calcification is increased, right? Serum calcium is increased, and this increased serum calcium deposits in living tissues. Okay, while the dystrophic calcification, this increased serum, I mean the normal serum calcium, which is whatever is present inside the blood, will deposit in dead tissues. Particularly like some necrosis is happening, and all over that kind of an area, this calcium has an increased propensity to actually deposit over there. So this is the basic definition and basic difference of dystrophic and metastatic calcification. Let's talk about certain examples over here. You can talk about examples like atherosclerosis here. This is an example where calcium is depositing and which is an dystrophic calcification, isn't it? And in cardiac valves, In which condition? Rheumatic heart disease conditions, you can have cardiac valve calcification, which is possible over there. Another example can be TB lymph node, right? So these are basic examples of dystrophic calcification. Now, metastatic calcification, as far as this is concerned, you can talk about certain conditions where there is an excessive amount of calcium in the body, in the blood. So let us talk about parathyroid adenoma. Okay, so and all causes of primary hyperparathyroidism, okay, can cause an excessive amount of serum calcium. This can cause metastatic calcification, right? Primary hyperparathyroidism. Can you talk about a secondary hyperparathyroidism? Yes, chronic renal failure. In chronic renal failure, there will be obviously a secondary hyperparathyroidism. Why? Because your 125 dihydroxycholecalciferol will be decreased, and this goes to the parathyroid gland and it will eventually synthesize more amount of PTH, and therefore this can cause a secondary hyperparathyroidism, right? That means some other causes there, but due to that, parathyroid is excessively producing parathormone, right? And you can even talk about certain other conditions like vitamin D, excessive intake. You can talk about that as intoxication. So whenever a patient is taking excessive vitamin D, he is prone to develop metastatic calcification. Okay, you can have here, if you talk about certain tumors, what kind of tumors am I talking about? Meningioma is a best example, right? The other one, ovary, salivary gland, and thyroid. Meningioma is a tumor as it is. Now in these glands, if you talk about the papillary tumor, papillary thyroid carcinoma, salivary gland carcinoma, so in all the papillary tumors of these glands, you have some kind of typical calcification. So you will get the calcification in this particular format. Okay, so these are concentric rings of calcification, and these are present in these tumors. They can ask you in which of the tumors you get Samoma bodies. So these concentric rings of calcification, which is dystrophic calcification, are present in these 4 tumors. Okay, so please make a note of this. This is a probable question in the exam. Okay, Samoma bodies can be present in these kind of other malignancies also. So this is the basic difference that we are supposed to remember with respect to dystrophic and metastatic calcification. And please make a special note of Samoma bodies, right? So let's go to the next slide now. So let us talk about a very commonly encountered situation in the surgery OPDs, which is the most common benign lesion, benign tumor of the female breast, and that is none other than fibroadenoma. So the patient is typically a young female. So this will definitely help you to, if they are giving you a clinical case history, just look for how old is this female. If she is within the age of 20 to 40 years of age, typically they are speaking about this kind of fibroadenoma, provided you get all the other hints to prove that this is fibroadenoma. As far as the age is concerned, typically we say that this is a young female presenting with a mobile mass in her breast, okay, a well circumscribed mobile mass in her breast. And this can be a gross question also, so we can get questions in that regard. Right, so it is the most common benign tumor of female breast. Now, if you see this histopathology image, whatever is lying outside these branching structures, we are able to see certain branching structures, isn't it? So you know that these are part of the conducting system of the breast. I mean, if the the glands and acini, and from there you have the ducts that are coming and opening into the nipple. So these are parts of that particular area, and these are lined by epithelium, right? So definitely I can say that whatever lies outside is the stroma. And remember that this is a tumor of the stroma. This is a neoplasm. I mean, it's a tumor of the stroma. So I can say that it is an intralobular stromal tumor. Okay, so the stroma can be divided into an intralobular part and interlobular part, and in both cases you can have tumors in there. So if you can get myofibroblastoma, angiosarcoma, etc. from the interlobular stroma, and as far as intralobular stroma is concerned, you can get tumors like fibroadenoma. So if you see this here, this stroma that you can see in this particular tumor is so high, isn't it, that it has started compressing the lobular structures over here, isn't it? These are the glands. So what happens is that these kind of lobular structures have been compressed by it. So there are 2 patterns which are followed by this. These are very important to note: pericanalicular, intracanalicular. Okay, so these are your canaliculi which are lined by the epithelium. you have seen the stroma here and you have seen the canalicular component of the breast here, isn't it? So this is the glandular component and that's the stromal component. Now let me tell you something here. There are two patterns followed by fibroadenoma, and it is very important that you note this. These are the two patterns shown over here, and if you look at this particular part of it, this looks like a normal architecture of the canaliculi, isn't it? The canaliculi is having a good diameter over here, good lumen over here, and the stroma is not compressing it. So the stroma is around the canaliculi only, not compressing it or not impinging on it. So since the stroma is not compressing on it, we say that the stroma is around it, or I can say pericanaliculi, around the canaliculi there is stroma, isn't it? And the second one are these kind of structures which are seen over here. It is extremely congested. What has happened over here is that the stroma has impinged upon the canaliculi, and this canaliculi lumen has decreased to such a great it has decreased to such a great extent that it is now in the form of certain very thin slits like this, isn't it? So this is the intracanalicular. Although you might feel that intracanalicular means that stroma is going inside the canaliculi. No, it's not like that. It is just compressing it to such an extent that it is making into a slit-like appearance, a very thin slit-like appearance, right? So this is the very important point so far as the histopathology of fibroadenoma is concerned, and you are supposed to write this. Along with that, can you comment on the stroma here? Stroma is a very, you can say, myxoid stroma, isn't it? Myxoid, mucin-like stroma, a very thin, delicate stroma, delicate. So you can describe the stroma in this way, myxoid, delicate, and it is, cellularity is very low. So I can say cellularity is very, very low in the stroma here. So it's just a myxoid, mucus-like, very delicate, slightly basophilic also. Cellularity is very, very low over here, and this is how a typical fibroadenoma section will be presented to you in the exam. It's very easy to diagnose this. It is very easy to get that whatever they are showing is fibroadenoma from just by one look at it. And then if you see, if they are giving you the history also, then there is nothing difficult in that. It's very simple and it's highly benign also. So yes. So I would like to take you towards one important sentence here. There is proliferation of stromal and epithelial components. So we discussed that this is a tumor of the intralobular stroma. So how can the epithelial cells also proliferate? So there is a proliferation of stroma and epithelial component is also proliferating. So understand what is epithelial component first of all. We are having these kind of ducts, isn't it? Canaliculi can be seen over here, isn't it? The glandular component can be seen over here. These are the canaliculi definitely. Whatever is lining this canaliculi, these are called by the name of the epithelial component. So there is a proliferation of not only the stroma but also the epithelial component. This is what is mentioned, or this is what is meant by the word proliferation of stromal and epithelial component, right? So it is clearly mentioned in the Robbins that whenever you are having an intralobular stromal tumor, stromal tumor within the lobules, isn't it? Stromal tumors within the lobule that is developing inside the lobule, whenever the stromal component is proliferating, that leads to a reactionary proliferation, that leads to a secondary proliferation of the epithelial component also. Right, epithelial component, that means whatever is lining the ducts, whatever is lining the canaliculi will also proliferate, and that is why you are having proliferation of not only the stromal but also the epithelial component. So that is why we typically call the tumors which are the intralobular stromal tumors as the biphasic tumors. Okay, so just a extra point to remember here, biphasic tumor. So obviously fibroadenoma will be a biphasic tumor because there is proliferation of stromal and epithelial component. But what type of tumor is it? It is an intralobular stromal tumor. Please be very sure with that. Now, whenever we talk about the canaliculi, you will be seeing that the walls of the canaliculi are made up of two layers of cells. Whatever lies outside is known by the name of myoepithelial cells. Okay, so these are the myoepithelial cells. Yes, it has the property of contraction. So milk ejection is the property of myoepithelial cells. It can contract, and whatever lies inside, which is pointing towards the lumen of the canaliculi, are called by the name of luminal cells. Luminal cells, right? So yes, myoepithelial cells are dependent on vitamin A. And if there is a shortage of vitamin A, this myoepithelial cells will undergo squamous metaplasia. Squamous metaplasia. What is metaplasia? Change of one adult cell type to another adult cell type, which can be directly asked in your viva also. Change of one adult cell type to another adult cell type. So this becomes squamous. right? Whenever there is a shortage of vitamin A, and that can lead to other problems also. So this is a basic idea that I wanted to share with you, a very basic fundamental property of the breast canaliculi, right? So I hope you have understood the basic features of the fibroadenoma and how you are coming to a diagnosis of this. We again have a surgery case over here, capillary hemangioma, and its histopathology. So first of all, let's understand the meaning of hemangioma. So it's a tumor, obviously the OMA word is there. So hemangioma is a tumor which is comprising of blood vessel containing tumor. So this is a blood vessel containing tumor, and that is called by the name of hemangioma. Blood vessels filled with blood are present in a tumor like this, and we have types of hemangioma, isn't it? We have capillary hemangioma, cavernous hemangioma, we have a juvenile hemangioma, pyogenic granuloma. So these are certain examples over there. So if they are asking us to enlist the types, we'll have to write that, right? So capillary, juvenile, cavernous, and this pyogenic granuloma can also be written, right? So yes, that's the fundamental idea so far as hemangioma is concerned. Now capillary hemangioma simply means that whatever be the blood vessels over here, we are talking about a tumor which has blood vessels, whatever be the blood vessels here, that will be in the form of capillaries. So a single cell lining will be there, isn't it? A thin lining will be there, a single cell lining will be there for this. And yes, that's how it is written, isn't it? Thin walled blood vessels. Why? Because they are capillaries. So capillary sized, so blood vessels which has the size of capillary, which has a thin wall, and these are made up of endothelial cells. So capillaries are lined by endothelial cells. Similarly, here also it will be lined by endothelial cells. But remember, the endothelial cells that are lining the vessels here will typically be a plump endothelium. So it's a big endothelium. So you cannot very easily appreciate these plump endothelial cell feature in this particular image. So I think we'll have to zoom inside to see more clearly the lining of the blood vessels that are found in this kind of a tumor, right? And yes, a very little amount of stroma will be there, and these stroma will be present in between the blood vessels which are present over here. Now let's actually talk about the sites, and we can expect questions on that. Sub questions, we don't know how difficult the sub questions will be. So yes, the sites most commonly, we know that hemangioma as such is going to occur most commonly in occurs in children and newborns and children, isn't it? It is that kind of a situation that we can think about whenever we hear the word hemangioma. So yeah, blood vessel tumor, tumor containing blood vessels are very typically seen in very young children. That means newborn children and very young children, isn't it? Little children. So it comprises hemangioma, not capillary hemangioma. Hemangioma as such comprises of 7% of all the benign tumors of infancy and childhood. So of all the benign tumors of childhood and infancy, 7% of all those tumors are hemangioma. Remember, it is a benign tumor, so they can extend, they can get bigger, and suddenly they can regress also, right? Now as far as capillary hemangioma is concerned, it is present most commonly in sites like skin is a site. You can have this in the mucous membrane, right? That is again a site, and you can have that in the subcutaneous tissue, right? So yeah, not just restricted to skin. In the Robbins, you have an image of a patient who has capillary hemangioma over his tongue. So mucous membrane, definitely, isn't it? And subcutaneous tissue, what lies inside the skin is called as the subcutis or the subcutaneous tissue. Now again, it can also occur inside the internal organs of the body. Very commonly, if they are asking you which is the most common site of hemangioma within the body, inside the body, in the visceral organs, you will say liver. Liver is the most common site. Overall, most common site will be skin, mucous membrane, subcutaneous tissue, here somewhere. But inside the body, if they are asking which is the most common site inside the body, it will be liver. And you can have it in the spleen, you can have it in case of kidney also. So these are certain sites that you can remember where this kind of a tumor develops, right? So the stromal component is very less, and that will be present in between the blood vessels over here, and these are the blood vessels over here. The first first impression that I'm going to get when I see this is that this is my epidermis, this is my dermis, and this is the dermoepidermal junction or the basement membrane. So this is a skin section only, which is showing a tumor, and this tumor is having blood vessels like this. So these are the capillary sized blood vessels of which they are talking about, isn't it? And you can see blood inside this, isn't it? So yeah, we have a lot of spaces over here like this also. We have numerous spaces also which are not, we cannot see any RBCs there in this particular view, in this particular image, but still these are spaces which are there inside the dermis or the subcutis. So yeah, and typically there are many blood vessels which contains the blood. So yeah, that is a diagnostic feature whenever they give you a slide of this disease over there. So these are the blood vessels which contain the RBCs, which are red in color. So these red things are the RBCs or the blood. So I hope this was fruitful so far as the capillary hemangioma is concerned. So let's go to another next slide that we are supposed to discuss. So perhaps the easiest of all tumors, the most easiest tumor to understand whenever they give you a slide is obviously the lipoma. So fat cells can be seen over here. So what's the characteristic feature? These are the big cells that you can see over there, which were full of fat, and as it was being processed in the laboratory for making the slide, what has happened is that whatever is the fat that got drained off, just like what we discussed in renal cell carcinoma, there was a lot of glycogen and fat in renal cells and they also got washed out. Likewise here, typically the fat whatever was there, that also got washed off. So you can see here lobules of adipocytes which are surrounded by fibrous septae, right? So you can see the septae here, isn't it? Septae can be demarcating each individual cells, and these adipocytes have clear cytoplasm and a peripherally pushed nuclei. So if this is the cell, then the nucleus will be somewhere in the outside, isn't it? So this is how the typical cell will look like, and this is how everything has been shown in the figure also. And septae shows the blood vessels and nerve bundles, obviously. So there are adipocytes are surrounded by septae. These septae show what the blood vessels and nerve bundles, and everything is encapsulated tumor. This is a tumor which is encapsulated by a fibrous septum. So you have an encapsulated tumor. Inside you are having, if you take the microscopy here, you have adipocytes with clear cytoplasm because the fat has been washed out during the processing, and the fat had to be accumulated in this particular cell. So here comes the fat, and that is why the nucleus was pushed to one side, right? So these are certain characteristic features here, and these are separated by thin septae. And yes, this thin septae contains nerve bundles and blood vessels. You can see a blood vessel here, isn't it? These red colored structures inside will be the RBCs. Very easy kind of a slide. Now I got a question when I got this as a gross specimen. The faculty had asked me a question, that is, can you give some secondary changes over here? So remember certain secondary changes here. Myxomatous change. Okay, myxomatous change is a secondary change or a complication, you can say. Right, you can have inflammatory change, myxomatous change, inflammatory change. You can have calcification here. Okay, so you can have calcification, and very rarely, I don't prefer to say that particular word in the beginning of the secondary changes. Never do that. Only after saying everything, if at all you are supposed to answer one more point, even after saying myxomatous change, inflammatory change, calcification, then say it can become malignant. This is extremely rare. So as per the surgery textbooks, I think that they say that malignant change of the adipocytes which are forming the lipoma, here whatever adipocytes are there, that becoming malignant is non-existent in nature. That is not at all there. And this malignant tumor called by the name of liposarcoma, I think you will not be able to visualize everything over here. So this malignant tumor called as liposarcoma is actually not from lipoma. It is a different kind of an origin for that tumor. Primitive mesenchymal cells are going to form the malignant cells and not a secondary change in lipoma. So this is there, but yes, it is supposed to be extremely rare, and yeah, only if you have said everything and then you are again asked to give another secondary change, you can directly go for a malignant change. But never say this in the beginning, because it is almost non-existent for a lipoma to become liposarcoma. Like the patient had a lipoma, now it becomes a liposarcoma, is almost, you can say, very rare or non-existent in nature. So where can you find this? This typically, is there any mutation for this? I don't have much idea about that, but it has been described that in multiple endocrine neoplasia syndrome, or in case of Cowden syndrome. Okay, so multiple endocrine neoplasia and Cowden syndrome patients can develop multiple lipoma, and where are the common sites here? Back, neck area of the body, and the trunk area of the body, and the limbs also, in lower limb, upper limb, back area, neck area. So these are certain sites of predilection for lipoma to arise. So that is all for lipoma. Let's go to the next one. In atheroma aorta, we are having aorta in which this atheromatous plaque is deposited towards the luminal side. So we have three layers for vessel wall, isn't it? In a vessel wall, we have 3 layers. Tunica intima will be somewhere over here, and you have a tunica media. So you can see this particular muscle cells. You can see spindle kind of cells over here, isn't it? The cells in this particular part of the histopathology image shows that these are the spindle cells. So obviously these are muscle cells, smooth muscle cells, and where will the smooth muscle lie? So this is my tunica media. Okay, so if I go beyond this, somewhere over here, I will get the image of tunica adventitia also, right? So in a field of view, I am presently getting these many things. So tunica media, and you will have a tunica intima over here, and above that, on tunica intima, whatever is lying over here, this particular region is the atheromatous plaque, right? Atheromatous plaque. Now the description of atheromatous plaque is done, or the pathogenesis is dealt by a very important hypothesis called as response to injury hypothesis. So it is called by the name of response to injury hypothesis. Okay, so the whatever is the event that is starting the atheromatous plaque formation is the injury to endothelium. Injury is occurring to the endothelium or the tunica intima. Whatever is most inside, the luminal surface of the blood vessel wall is having some kind of an injury. Now when there is an injury, then as a response to this injury, something is coming and attaching over there, something is coming and overlaying over there, and that eventually leads to the formation of atheroma aorta. So it's an inflammatory change in a way. So injury occurs, and what happens is that LDL will come and bind to that particular area. So I'm just describing this in the simplest way possible. Injury occurs in the tunica intima or the endothelium. As a response to that, LDL and its oxidized form of LDL, its oxidized form will come and bind over to this, and then after some time platelet will come and bind over there, then comes the monocyte will come after LDL has come and bound over there. Okay, it gets bounded, and this monocyte will transform into macrophages, right? And yeah, this becomes macrophages, and then what happens is there will be fat accumulation within the macrophages. So you can say this becomes foamy macrophages. Okay, so you will get foamy macrophages. That means monocyte has come and come to that particular area, and that transforms into macrophages, and in this macrophages you will be able to appreciate fat content, right? And after this, what happens is the smooth muscle cells will come to that particular area, and this will proliferate. So we had an injury, and LDL and its oxidized form came to that area, then platelet and monocyte came to that area, monocyte transforms into macrophages, and this macrophage becomes foamy macrophages, and that eventually leads to the formation of the recruitment of smooth muscles to that area. Smooth muscles will proliferate everything in this particular area. This forms an atheromatous plaque. So initially you will get something called by the name of a fatty streak. A 1 centimeter long yellowish kind of a discoloration can be seen whenever you have an aorta when it is opened. So these kind of simple things are the initial lesions which are progressing towards an atheromatous plaque. So these are called by the name of the initial lesions or the fatty streak. Fatty streaks are the initial lesion. Okay, right? And then as it progresses, it becomes an atheromatous plaque, like what is shown over here. So we are supposed to know the structure of atheromatous plaque over there, right? So the structure of this particular acute plaque or atheromatous plaque over here is somewhat like this. So initially on the top you have a cap. This cap is made up of the smooth muscle cells. I said that towards the end of this particular process, I have smooth muscle cells progressing, coming to that area, isn't it? So the smooth muscle cells and the proteins like collagen over here, and many other cells also, lymphocytes and other things, mainly smooth muscles and the proteins here. Smooth muscle collagen will be forming the cap, right? Smooth muscle and collagen will be forming the cap, and inside the cap you are going to have a necrotic core somewhere over here, right? Inside the cap, beneath the cap, you have a necrotic core, and there comes all the lipid content in a atheroma, right? So we said that LDL and its oxidized form is coming over there, monocyte comes over there, and that becomes macrophages. So whatever is the fat over there that gets accumulated within the macrophages to form foamy macrophages, everything comes inside the comes in the necrotic core over. So that is why it is written lipid laden macrophages, cholesterol clefts and necrotic debris, right? And this core is surrounded by lymphocytes and foamy macrophages again. So yeah, you have a cap and you have a core. Cap is made up of smooth muscles and protein. Core is made up of all the cholesterol content, cholesterol crystals, the lipid-laden macrophages, cholesterol cleft lipid-laden macrophages, and you have a necrotic debris also present over there, right? So this is one important point to remember. Another very important point is the question that they can ask. This was also a gross specimen over there, so they can ask you the secondary changes over here. So in the secondary changes, it's a very probable question. We talk about something called by the name of acute plaque change. So there are changes inside the plaque, atheromatous plaque, which is an acute phenomenon. Acutely you are having a secondary change over here. So these acute plaque changes include rupture of the plaque is a very common possibility. Then we can have erosion or ulceration. You can call it by the name of erosion or ulceration of the plaque. So that can be detrimental, right? And you can have hemorrhages into the plaque is another important secondary change. So rupture, erosion, ulceration, you can have aneurysm. Aneurysm is a very important possibility. You can have thrombosis. This can become a thrombus, isn't it? Thrombosis, and that can go for an embolization also. So embolism. So these, at least these should be very much thorough. And this is a very probable question. What are the secondary changes in atheroma, aorta, or atheromatous plaque, right? So yes, the topic that you can revise over here is the complete process of arteriosclerosis and atherosclerosis, which is there, isn't it? We have classified into 3 types, and here comes the atherosclerosis. Now, one important type is atheroma aorta, and yes, aorta is the most common site for atheromatous changes, right? Among all the arteries in the human body. So let's go to the next. So let us talk about Hodgkin lymphoma slide here, right? So what makes a Hodgkin lymphoma very characteristic is these kind of cells here. So you can see a cell over here. You have a bilobed nucleus. So there are 2 lobes for this nucleus, and these 2 nuclei are mirror images of the same. Okay, so this is the nucleolus here. So this is how the bilobed nucleus will appear, and these 2 lobes of the nucleus are mirror images of each other. So these cells are typically called by the name of Reed-Sternberg cells, right? So we are supposed to know this as the most important classical feature of Hodgkin lymphoma. It has a length, diameter of around 15 to 45 micrometer in diameter, right? Yeah, so this is the fact here. So what do you call this? 2 eyes of an owl, isn't it? So this is called by the name of owl eye appearance. So we typically call this by the name of owl eye appearance, which is a characteristic feature of the Reed-Sternberg cell. So as far as the CD markers are concerned, it is CD15 and CD30, right? So for immunophenotyping, you will be using these 2 markers, and these are expressed by the typical normal Reed-Sternberg cells over here. So these are the characteristic features. This is a zoomed in image, and here you can see cells like these are your Reed-Sternberg cells over here. You can see cells over here. Many big cells can be seen. So these are Reed-Sternberg cells. Although their morphology cannot be very clearly and classically appreciated here, if you go for a better zooming, you will be able to see that. Okay. So Hodgkin lymphoma, what is the most important risk factor? Most important risk factor is Epstein-Barr virus, obviously. Epstein-Barr virus is the most important risk factor here. It causes not only Hodgkin lymphoma, but it causes other tumors also, isn't it? Hodgkin lymphoma can be caused by it. Non-Hodgkin lymphoma can be caused by it. Then the nasopharyngeal carcinoma can be caused by it, okay? And Burkitt lymphoma. So Hodgkin, non-Hodgkin, Burkitt lymphoma, and nasopharyngeal carcinoma. So these are certain examples of tumors which are caused by Epstein-Barr virus, which is an important question. Okay, this is a very important risk factor here. So we have this particular NF kappa beta. So this is a very important compound which is present inside the B cells, isn't it? It has an overactivity whenever you have a tumor like this. NF kappa beta overactivity can be seen in the B cells, right? So there is something called by the name of inhibitor kappa beta. So this I kappa beta will be actually inhibited. So the inhibitor is inhibited by Inhibitor is inhibited by Epstein-Barr virus. So Epstein-Barr virus will inhibit the inhibitor. So NF-kappa beta will be increasingly present. The activity of NF-kappa beta will increase, and that leads to the formation of the tumor like this. Now, histology, the basic histological feature or the basic histopathological feature of Hodgkin lymphoma is that you have Reed-Sternberg cells in an inflammatory background. So here you can see here, this is an inflammatory background, isn't it? You have a lot of lymphocytes here, lot of plasma cells over here, lot of monocytes over here. So these kind of mononuclear phagocytic cells can be present over there, and plasma cells are also present. So in this inflammatory background of plasma cells, monocytes, and we have this lymphocytes. So this is the inflammatory background. In this inflammatory background, you will be seeing these Reed-Sternberg cells. So Reed-Sternberg cells in the inflammatory background is the classical feature of the histopathology of Hodgkin lymphoma, right? So that is the basic idea that we are supposed to have. So let us throw some light on the types of Hodgkin lymphoma. We are classifying it as classical and non-classical, provided if your Reed-Sternberg cell is CD15 and CD30 positive, you call it by the name of classical types. And if it is CD15 and 13 negative, but it is CD20 positive, we will talk about that particular cell over there, then it becomes non-classical. Only one subtype is there in non-classical, rest everything is in classical. So we are supposed to remember the name and some basic points regarding that. Nodular sclerosis is the first type, okay? Nodular sclerosis is the first type. The basic word reminds me of a collagen deposition, isn't it? A connective tissue deposition, sclerosis is present, nodule formation is present. Here, remember, this is the most common throughout the world. Most common type of Hodgkin lymphoma throughout the world is nodular sclerosis. Point to remember is that the type of Reed-Sternberg cell is called by the name of lacunar cell. Okay, so lacunar cell is the type of Reed-Sternberg cell seen over here, right? So this will eventually secrete transforming growth factor beta. This increases the connective tissue formation. So that is the reason by which there is a sclerosis in that particular type of Hodgkin lymphoma, right? You will see excessive connective tissue there. Why? Because of the presence of lacunar cell. Now mixed cellularity is the you can say most common type in India. Now the point to remember is that here multiple cells can be present here. Reed-Sternberg cells can be there, lymphocytes can be there, eosinophils can be there, plasma cells can be there. So there is a mixed cellularity, multiple cellularity will be there, and you will be seeing the mononuclear cells, which is a type of RS cell only, right? Mononuclear cell. Here it was lacunar cell, here it is mononuclear cell. Lymphocyte rich, lymphocyte depleted, lymphocyte predominant. So this is the, you can say this is a part of non-classical, right? So if I tell you that if the number of lymphocytes are increasing, it is seen that it is having a better prognosis. So prognosis is proportional to number of lymphocytes, just a kind of understanding that we can have, just an understanding that we can have so as to get this correct. See, among classical, tell me which will have the best prognosis. The best prognosis will be by that particular subtype which has more lymphocyte. Among this, maximum lymphocytes are here, so this has the best prognosis, right? Among classical, best prognosis among classical subtypes, right? Now, all together, if you see throughout, if you take all types of Hodgkin lymphoma, classical and non-classical together, overall best prognosis is for lymphocyte predominant. This is the best prognosis overall, right? This is the best prognosis overall. Remember that in lymphocyte depleted, the number of lymphocytes are very less, so therefore I can say this has the worst prognosis. Okay, now you have a point to remember over here, which is the most important point. That is, I said that whatever cells are here, the Reed-Sternberg cells are CD15, 30 and 13 negative, it is CD20 positive, right? So these typical very special types of cells are called by the name of popcorn cells. Okay, remember this. So popcorn cells are seen in lymphocyte predominant type of Hodgkin lymphoma, which is a non-classical Hodgkin lymphoma. Okay, so let's go to the next slide. Now let us talk about a very simple kind of a tumor, a very benign tumor called by the name of leiomyoma. It's a very benign tumor that is not at all malignant. There is no malignant transformation also. So whatever we learn as leiomyosarcoma, which is a malignant tumor of the uterus, is actually arising de novo and not a secondary change of leiomyoma. Remember that. It is not a secondary change of leiomyoma as such. Right, so leiomyoma, remember that here the female is typically a female of reproductive age group. So this is a very important point, reproductive age group. Right, so you will have a female of reproductive age group. Typically a female will be around the age of 30 to 50 years of age, and this is affecting around 50% of the females who are in reproductive age group. This is a very common 30 to 50% of females who are in reproductive age group, which is almost in 30 to 50 years of age, can develop leiomyoma, and even lesser age groups are also have started to develop leiomyoma, isn't it? So when I have a image like this, the first impression that I get is that this is full of smooth muscle cells. How do I understand that this is smooth muscle cells? Because of the typical morphology of smooth muscle cells, which are spindle type cells, and you have a nucleus which is in the center, isn't it? So something like that has been seen over here, and there are whorls of cell like this. So they are forming a whorls of cells. Bundles of smooth muscle cells can be seen over there, and it is highly uniform. So highly uniform shows that it is almost a benign kind of a phenomenon. So you can see here whorled bundles of relatively uniform smooth muscle cells with rare mitosis. So this is the picture that you can get whenever you see the microscopic view of leiomyoma. A very benign kind of a tumor, very typical and alike looking, similar looking smooth muscle bundles can be seen over here. So that's how you actually find out that this is the slide of leiomyoma, and there are certain variants that can express increased cellularity and atypical cells. Atypical cells are like what? When do you call a cell as atypical? These are certain ideas that point towards malignancy, isn't it? So there are certain variants of leiomyoma that can show these kind of slight atypical features. That is what is meant by this particular part of the sentence. Variants can exhibit increased cellularity can be there, or atypical bizarre cells can be there, right? So identifying leiomyoma is very easy, and writing the answers for leiomyoma is also very easy. So yeah, smooth muscle appearance can be there, which is the most characteristic feature, because leiomyoma as such is a tumor of smooth muscles. Now, do you know something about etiology of this? Etiology of leiomyoma has not been properly and completely understood till now. So they say that yes, since it's a female of reproductive age group, the females typically have an excessive amount of high amount of estrogen in their body, isn't it? So estrogen exposure is something that is said to cause, or it is said to see it is said to be seen in people who are suffering from leiomyoma, and therefore I can say that OCP taking females have a higher chance of developing leiomyoma. So these are certain studies which had shown that okay, in people who have leiomyoma, there is an increased amount of estrogen, and yes, estrogen exposure can be in the form of oral contraceptive pills. Another important feature, if you talk about the genetics here, completely proven genetic predisposition is not there for any leiomyoma tumor, but certain genes have been mentioned in our textbook, like the MED12 gene. You can remember this MED12 gene. If there is a mutation in that, if there is a change in this particular gene, then there is an increased predisposition for developing leiomyoma. Chromosome number 6 and 12, if there is any rearrangements in these two chromosomes, then it is also tends to show a leiomyoma, tend to show an increased risk of leiomyoma in that particular female. Yes, let us talk about certain secondary changes over here. You can have hyaline degeneration, right? You can have cystic degeneration. Now, the most important point that I would like you to remember is the red degeneration. Red degeneration is actually due to what you can say a hemorrhagic thrombus inside the leiomyoma. So some hemorrhage is happening over there and it appears red. So this red degeneration of leiomyoma, I think this is a very important word. This is a very important point to remember. This is seen in pregnancy. Right, so this is what I would recommend you never to forget for the exam. Red degeneration is seen during pregnancy, right? Okay, so let's go to the next slide now. Acute appendicitis. Here the point is that it's an acute inflammation of the appendix here. So most important point that I consider is all layers show neutrophilic infiltration. So that is an important must know point, and along with all the other points, make sure that you are writing this, right? So all layers, especially muscularis propria, should be having neutrophilic infiltration, and then you will be making a diagnosis of acute appendicitis. So there is an ulceration in the lumen here. So this is the lumen, right? And these are the walls of the appendix, and we have a small lumen here, and I can see a lot of glands in the wall like this. A lot of glands can be seen over here. Now, the point is that the lumen will undergo some kind of an ulceration, and whatever is the material inside will come out. So RBC, macrophages, and the necrotic material can be present inside the lumen, right? So yeah, necrosis can occur. The blood vessels supplying the appendix can be dilated, and all the features of inflammation will be there, and yes, neutrophilic infiltration will be there. So continuity of epithelium is lost, and that leads to ulceration of mucosa, right? So these are the points with respect to acute appendicitis. Let's go to the next slide. Now let us talk about mature cystic teratoma. So you are having ovarian malignancies, isn't it? Ovarian malignancies are too many in number, but we are supposed to remember some names and very important clinical features of, very important pathological features of all of them, some of them at least. So mature cystic teratoma is a germ cell tumor. This is a germ cell tumor. How do you divide the tumors of ovary? We divide it by, you have a surface epithelium for ovary, you call it as surface epithelial tumors. Then you have inside the sex called stromal tumors like granulosa is a connecting stalk-like structure, and these are certain components of the follicle in which ovum is present, isn't it? So granulosa cell tumor, Sertoli Leydig cell tumors, etc. are there. And along with that we have the germ cell tumor. That means it is arising from the ovum and the predecessors or the precursors of ovum. So whatever is arising from that ovum is called by the name of germ cell tumor. Now, what is happening here? Self-fertilization of ovum has been accountable for these kind of formation of teratoma here, isn't it? So teratoma, what is there inside this? You have highly atypical kind of features over here. Atypical in the sense, see, if you just see this, I have a type of tissue over here, this is a separate kind of tissue, here I have something else, and here I have something else. So there are multiple kind of structures which are present inside the same ovary, right? So I can say that there are ectodermal components here, mesodermal components here, and endodermal components here. Ectodermal components like the neuroepithelium, isn't it? Neuroepithelium. So it is not just epithelium, I'll have to carefully say it as neuroepithelium because it can even have the brain and glial cells also there. And as far as epithelium is concerned, the skin can be present over there, like stratified squamous epithelium can be present over there. Mesoderm, muscles can be present, okay, cartilage, bone can be present over there. So these are certain mesodermally derived structures. Endodermally derived structures are the glands, right? So glands can be present over there, it can even secrete multiple substances, right? So these are certain characteristic feature of mature cystic teratoma. You have multiple other things over there. Now if I start dividing teratoma, if I start classifying teratoma, I will get three classification, three components, these three types. One is called by the name of mature cystic, right? The second one is immature, and the third one is specialized teratoma, right? Mature cystic means it has ectodermal, mesodermal, endodermal components. If all these components are together present, then I will call it by the name of mesodermal, mature cystic teratoma, right? Immature teratoma means it is not mature, so immature cells can be present, immature components can be present of everything like this. Now tell me which is malignant among this, which is benign, which is malignant. Whatever is immature is malignant, whatever is immature is malignant, and this is the malignant one. This is the malignant teratoma, right? This is the malignant teratoma. Mature cystic is benign, and even this is also sometimes benign. Why? Because it is specialized towards one particular structure. Instead of having lot of things within the same ovary, there it is specialized to one particular structure. What you call by the name of struma ovarii, right? So this will secrete thyroid hormone. I don't think it will be visible for you here. If the ovary is forming glands and that is going to secrete thyroid hormone, it is called by the name of struma ovarii. It is an important word, okay? So this is an important word in pathology, right? And even you can have ovarian carcinoids also. So that means it is secreting serotonin. So these are certain examples where the teratoma is specializing towards one particular cell type, and that is doing its function like it is present on normal areas of the body. So yeah, if thyroid gland is developing within the ovary, it causes thyroxine secretion, struma ovarii. If carcinoid secretion is there, carcinoid tumor is developing inside that, instead of forming everything like this, it is going to form only one kind of structures, and that structure performs its function, and you can have secondary changes because of that, right? So this patient can have hyperthyroidism. The normal thyroid is producing and the ovary is also producing. So yeah, struma ovarii can present in that way. So this is the basic idea of a germ cell tumor, mechocystic teratoma, ovary. Now remember, when you consider the teratoma, the cystic teratoma here, on the wall of the cyst you have a particular protuberance here, right? And it is from these protuberance that all these structures are developing. It is from this protuberance that all these structures are developing. Do make it a point to note this. This particular protuberance is called by the name of Rokitansky protuberance. So this is a very important word that you can remember. Sometimes they can ask this, right? Another important feature to remember is that how are you going to classify this? How are you going to make a diagnosis whether it is a mechocystic or immature or specialized teratoma? What exactly will you look for in the histopathology so as to differentiate it as a mechocystic or immature, which is malignant, or a specialized? You will look for the immature component. You will look for the immature component, typically the neuroepithelium. You will look for these kind of structures to say that it is benign, I mean it is immature, or whether it is mature. So the immature components within a teratoma is what you look for, so as to call it as an immature, or if that is absent you will call it as a mature, isn't it? So to categorize this, you are going to look for the neuroepithelial structures which are present inside the teratoma. This was a question that was asked to me. So yeah, I am making that point also clear here. Okay, let's go to the next one now. Names of the germ cell tumors of the ovary. The first one is dysgerminoma, right? You can have choriocarcinoma, embryonal carcinoma, you can have teratoma, yolk sac tumor, right? So these are the names that you are supposed to remember in germ cell tumors. Then there are certain other tumors also, you can remember the names of that also, and some basic points regarding that also. Now these are certain genes which are associated with ovarian malignancies as such, not just teratoma, ovarian malignancies, BRCA1, KRAS and DNA mismatch repair defect, BRCA1, KRAS and the DNA mismatch repair defects, right? So I am stopping this video for now. Even though I tried to complete all the slides in this particular video, it was not possible. So let's take one more video for the rest of the remaining few slides.